Hi, and welcome back to the second session of today. We've now got our roundtable panel discussion, so dietary management and update in irritable bowel syndrome. So my name is Rachel Buckle. I'm one of the gastroenterology dietitians here in Sheffield, and I'll be chairing this morning.
I'm Emma Stennett, and I'm gastroenterology dietitian at Guy's and St Thomas's.
And I'm Bridget Wilson. I'm a clinical and research gastroenterology dietitian.
And obviously we've got our wonderful panel here, and you can read as we've got for you lots of interesting information about them. They've all done so much. But just a quick introduction for who we've got here. So we've got Nick Trott, who's a gastroenterology dietitian here in Sheffield. Christian, who spoke this morning, who's a gastroenterology dietitian and advanced clinical practitioner here. We've got Kirsten Jackson, who's a consultant IBS dietitian. And we've got Kate Scarlata, who's kindly come over from the US, who's a dietitian and leading IBS expert. And then we've got Dr. Amanda Avery, who's an associate professor of nutrition and dietetics at Nottingham University and has been working in the area of irritable bowel syndrome for many years. So this morning, just to get us started off, obviously we're going to be talking a bit about an update in dietary management in IBS. So obviously things have changed quite a lot over time, and we've had a real development in terms of what's available to us. And I was wondering, to start off the discussion, whether any of our panel had any comments about that sort of development over time and where we are now.
I think I can maybe add something into that, Rachel, because for better or for worse, I can remember when I first started in dietetics a few years ago now, more than I care to mention, is I can actually remember when patients referred with IBS, we struggled as dietitians to know what to do. They often came in with a very disparate range of issues about food, and we didn't have a formalized structure to be able to treat them. I think me and Amanda will remember we used to have a pork and rice diet at one point that we used to have to use. I'm sure some of you will remember. So I think what we want to do is recognize how far we've come in dietary treatments over the last few years. You know, with the advent of treatments like the low FODMAP approach, you know, it's really revolutionized what we can do dietetically. So I think it's important to see we've got a way to go to understand how to treat these patients, but equally it's important to turn around and see how far we've come, I think, in this area, you know, so it's encouraging. I think if we look at the next slide as well, Rachel, I think one thing is to say is that patients have a discrete preference for dietary treatments, certainly in this Dutch study. So we know that patients want dietary treatments for IBS. So I think we've got a space that we can own as clinicians, as dietitians here, that, you know, it's important. I think we recognize that it's a really important treatment. Yeah. But with other members of the panel, would that be their experience of working in this area?
Nick, I was going to add, given the length of time I have been around, that sort of in the old days, I remember the wheat bran days when sort of fibre was potentially encouraged, and then of course there were concerns about people having too much fibre. And so I think you could almost look at a journey of different fibre intakes over the years in terms of dietary approaches to IBS, which I think is quite fascinating. You know, on the one hand, many years ago, perhaps people were encouraged to have more fibre, and then with sort of newer dietary approaches, fibre's been discouraged, and certainly the low FODMAP diet tends to have quite a low fibre intake associated with it. So to me that's quite fascinating, and as dietitians, perhaps we go to extremes at times, and perhaps we need to find a balance, because clearly dietary fibre is terribly important in terms of a healthy functioning gut. So how do we get it right in terms of the right dietary fibre intake for this population group, I think is really interesting.
I agree, and I would say in the right hands, a low FODMAP diet does not have to be low fiber, and that's where dietitians really make a big impact, because there are plenty of fruits and vegetables and fiber supplements that are certified low FODMAP. So it's always a talking point that should be included in any low FODMAP diet education, because although it has been in free living populations adapting the diet, it can be low in fiber. It certainly does not need to be.
And I also would just add to the whole diet thing, I think it's very easy for us as dietitians to get very excited about this kind of information, research coming out showing that this is what patients want, they're expecting, you know, a nutrition change. However, there was a really good review by Heidi et al., I think it was like 21, and it was looking at GI conditions and also the link between mental health. And it showed, unfortunately, there's still that big taboo that, around mental well-being. And it could actually be that even though nutrition is very important, we're maybe undervaluing other areas with our patients. So just always thinking about that multifactorial approach is what I would say as well.
Yeah, because I would equally, I know this is about dietary treatments, but we know, I think, from the evidence base that the best treatment for these patients is multidisciplinary. So yes, we're looking at the diet today, but I think we just want to acknowledge it's important that if we want the best outcomes for these patients. I saw a very interesting interview with one of Kate's colleagues, Dr. William Che, the other week, who emphasizes that point about integrated care being the best outcome. So I think, within the framework of the discussion, we're talking about diet, but really we want to see patients getting treated in a number of different ways. And I think that nicely maybe leads on to our next slide at another discussion point, is about how we actually do the research in this area. So I wonder if we just get a show of hands, when we think about the research in the area, would people feel they would know the methodologies that are used in terms, if I said double-blind placebo-controlled food challenges, would people have heard of that as a methodology for studying it? Yeah, I can see a few heads. And then, obviously we have more pragmatic dietary trials where we just give someone a diet, or we'll do feeding trials. So I'm curious about what the panel think and what questions would come in. When we particularly think about a double-blind placebo-controlled food trial, so when someone's given like a muffin or they're given a bar that has the object of interest in it, that could be fructans or gluten or another aspect, amylase tryptase inhibitors, other non-gluten proteins in food, do we think that relates to real life, to what we do in clinic? And I suppose that's a caveat to me, and I wonder if anyone on the panel thinks about that as well. When we look at some of the research about what drives symptoms in these patients, when we're using a methodology like that, do we think we need to have that in context or aware when we're thinking about the results?
Yeah, absolutely.
Just makes a movement forward to more pragmatic studies, doesn't it? What are patients doing in real life? I think that's what we need to think about going forward, rather than always relying on things like the double-blind placebo-controlled trial. It's about that individual, about what is that individual presenting with, what symptoms do they have, what do they suspect are triggers. We're moving towards this personalisation approach with many things now, and I think this is probably the future of IBS as well.
I was very lucky enough a couple of years ago, so there's a very famous trial, the Scody paper, which is an excellent paper where they compared it was like flapjack bars, so they compared placebo, like negative, to fructans to gluten. And it's a very famous trial. And when I was interviewing one of the primary, or having a discussion with the primary authors, it's Knut Lunden, who's based in Norway, and he was saying placebo-controlled trials, they may give us an indication, but in that trial, 16 people reacted to gluten, 24 reacted to fructans, and 22 reacted to the placebo. So, he was saying it's a little bit difficult to find out what's really going on from studies like that, I think. So it's important, I think, we read into the data in that way. And I think this paper by Heidi Stordaker, if you've not seen it, this will all be available on the website. We'll try and make all these papers available. I'm sure some of you will be familiar with them. But it's a really interesting paper to look into, I think, about when we're thinking about the trials and how we understand what's going on with some of these papers. But again, would the panel sort of agree with some of that sort of stuff? I can see Amanda's...
Well, yes, yeah. I mean, I think, as Nick's alluded, when you're looking at the evidence base, it's really, really important that you do look at the methodology that's been employed. Obviously, as dietitians, we want to be evidence-based practitioners. Christian earlier really emphasised the importance of us being involved in research, but actually research in this area is actually quite difficult in a real-world setting. So, yeah, do explore the methodologies, because obviously things that you need to consider are the baseline diet in terms of FODMAP content, for example. If you're looking at the effectiveness of, adding a different type of fibre into a diet and seeing the response over a period of number of hours, then ideally you need to offer people a diet, so you need to provide people with food just to be able to control for the different variables. And of course, people need to have a reasonably healthy gut microbiome, so how on earth do we know if they have that? That can't be taking probiotic supplements or have had antibiotics for a certain length of time. And I don't know, just trying to find a meal that is low in FODMAP content that is suitable for all of your participants is likely to be quite difficult. So it is actually quite a difficult area to do research in because of all the other variables that could influence your outcomes of interest. So do scrutinise the methodology when you are sort of looking at papers in this area.
So just coming on to the dietary therapies then, so in the UK, I appreciate we've got Kate kindly visiting from the US as well. We use kind of a two-step approach, which is the current British Dietetic Association guidelines, which I'm sure you're all familiar with. So we've got first-line dietary advice, followed by the low FODMAP diet. So are we satisfied with the current sort of two-step approach? Is this adequate? Is there a requirement for more flexibility within clinical practice?
I think the first thing I would say very quickly is I want to respect the amount of work that has gone into this guideline historically. To do these sort of guidelines is just an incredible burden to actually come out with. So it's, again, you know, it gives us as a profession a way forward, but obviously this was a few years ago now. So I suppose I'm interested from the audience for people who work in IBS is how are they still applying this? Are you applying that quite strictly in practice? Are you doing it through groups or through webinar approaches? How are people doing it? I wonder if anyone in the audience has got a view on how they use this.
So we have got a roving microphone as well if people have questions as we're going through, and obviously we'll be taking questions as well from online.
I still find this extremely useful, because it gives us really clear guidance on first-line approach, because often a lot of the patients I see may only need a very simple first-line approach. So there's no point putting them down something really strict like a FODMAP diet if you don't need to. So I find these guidelines really, really useful. I certainly wouldn't ever use the FODMAP diet as a first-line approach. So I think they're still very relevant. Mind you, I'm sitting next to Yvonne, so...
Yeah, we really want to acknowledge that Yvonne Mackenzie, who was a primary author with this guideline, is with us, and we're really grateful for her work in this area. I'm interested, Kate, is the first line approach, is that something that's used in America? Would you call it that? What sort of, how would that be approased?
You know, I think most dietitians really do look at patients individually, and psyllium husk is numbers needed to treat is about 4, so that's kind of usually our go-to, and in the initial, you know, maybe just be simply trying a fiber supplement. But there are a number of patients that come, especially in this post-pandemic era, that their alcohol consumption is through the roof, and we know that can contribute to GI symptoms. So I think just really cleaning up the diet is certainly my approach first before delving into a more strict low FODMAP diet. And I think just the connection that we're really seeing, this emergence, although very nuanced, eating disorder mix with GI conditions, which will be spoken about later. We have to be really careful about screening for eating disorders and making sure that we're not embarking on, and we're seeing such a significant population that may not really be appropriate for the low FODMAP diet. So there's lots of factors. I think some of the newer dietitians are going straight into the low FODMAP diet, to be honest with you, and I think that there's a lot of just people doing their own thing.
Yeah, and I think that's so important to recognize that we need to tailor it, and even with the current guideline, we need to tailor it to the individual. It may be appropriate for some patients to jump straight to the low FODMAP in certain situations, depending on who we're presenting with. I think one of the issues that we've had in the UK is there's been less ownership and dietetic autonomy in the area, where we had real problems. I was lucky enough to do a bit of research from my master's looking at how patients use GI advice from GPs and gastroenterologists, and there was a lot of what I would call the Google handout going on, unfortunately. Yes. And I think this speaks to maybe what we would come on to with one of the slides about the low FODMAP diet in terms of its background efficacy. I wonder if we could jump forward a couple of slides there, Rachel, if that's all right. So we know it's a 3-phase process, and I know maybe Bridget can add in here as well. But if we go on to the next slide, I'm wondering if it's actually more of a 4-phase process, and what's really important is that patient selection phase as well. That thing about being able to do a proper IBS assessment.
Yeah, and
I think one of the challenges faced, particularly within the NHS, is patients may have been waiting quite a long time for their appointment with a dietitian. And when you're seeing them as a specialist dietitian, you want to help them as much as you can. You would hope, in most cases, someone's already had some first-line advice from a GP or maybe from a triaging dietitian before they come to you. But, if someone's already waited 6-7 months to see you, you don't want to send them away with only just a few little things. You want to try and be as impactful as you can, because next time you see them could be another 12 weeks and it's only a short appointment as a follow-up. And I think for that reason there is a lot of pressure to sort of jump in and give them what is perceived as the most effective treatment for IBS.
We certainly saw from our research a few years ago on the provision of dietetic services across the UK, across England rather, that patients are waiting 2 to 4 months on average to see somebody, and often they have received some information from a GP, and that can sometimes just be a leaflet. So by the time they actually get through to you into your clinic or your group session for a low FODMAP diet, in their minds they've already done a low FODMAP diet because they've had this information from a GP, but often that's just a short piece of paper with a few recommendations on. So I think we really need to try and improve the pathway if possible. And often there's none of that screening element at that point either. It seems to be almost that sometimes the traditional or the first line advice has been kind of forgotten and the low FODMAPs has taken over, and everyone's just using that or recommending that. And I think by the time they get to us, it's perhaps not done more harm, but it's they're not always invested then to follow it accurately, because in their mind they've already spent some time following a diet that they perceived that was correct.
I wonder.
Sorry, I think we've just got one comment coming through.
Sorry. I think that is brilliant. I really, really like that idea that should be a phase 1, because that is what dietitians are trained to do. We are trained to diagnose diet-related conditions, and that is not utilised enough. So in the clinic that I set up, it was very important that we would get a patient with a diagnosis of IBS. Was nearly all of our patients were given a diagnosis of IBS, but it was up to us to decide whether that was the correct diagnosis. And so that assessment, even though I've seen thousands of them now, I can't get under an hour for a patient. So an hour per patient for a first consultation, because by the time you've assessed everything and looked at whether allergy, whether celiac disease, all the different things, is there inflammation, are they pooing themselves 15 times a day, and you think, hang on a minute, this is not normal IBS. It's up to us to assess that and diagnose. So I really, really like that. I think that should be added.
Yeah, and hold that thought, Marek, because we'll come back to it with, I think, some of the roundtable work that we did together a few years ago, that, dietitians do need ownership. And that's how we scale that up in terms of specialist input, I think, in these patients when we're thinking within an NHS context, I suppose. But one thing I did do, because we're so lucky to have Kate here, is if we just move on to the next slide, Rachel, I was thinking, I did want to touch on a little bit, because I think one of the strengths of the low FODMAP approach is it does have a very strong sort of mechanistic basis to it, I think. And I think you were very lucky to be at DDW, which is everyone, hands up, have people heard of DDW here at all? A few people, yeah. So it's a big dietitians, I wish it was dietitians, it's digestive diseases week, isn't it?
Digestive, I know, right.
And what really came out in terms of what do you think's on the horizon in terms of mechanisms in this area, do you think?
Yeah, I mean, they're really drilling down this whole notion of barrier dysfunction, so that a high FODMAP diet and those that respond. So it's important to know that we know that only about 50 to 80% of patients respond to an IBS, to a low FODMAP diet that have IBS. And so, but in that cohort, when they've looked at them specifically, FODMAP ingestion leads to mast cell activation, intestinal permeability, initially with a dysbiosis, so that certain types of microbes are growing at greater rates. Those that tend to have, that are gram-negative microbes that have LPS, which drives this reaction of mast cell activation and intestinal permeability. So we're starting to, it's not just osmotic effects, fermentative effects, we're looking now at all these end products and what's happening downstream. There was an interesting sort of, with this barrier dysfunction connection, there was also sort of another adjunct talk from Prashant Singh, who works with Bill Che, who's really broken down this mechanistic effects of the LPS and mast cell activation, looking at the impact in this same cohort of patients, they have lower glutamine synthesis enzymes, which also reduces the intestinal permeability, and sort of building on some of these studies looking at glutamine as one way to enhance the permeability of the gut. So it is very, very interesting, but really looking at a dysbiotic environment that in certain patients with IBS, FODMAPs drive dysbiosis and then have these downstream effects which trigger the visceral hypersensitivity.
Wonderful. And I think, could I have a personal request? And I love the way you describe that about barrier dysfunction. So I have a bias, I'm going to admit it, that no dietitian should ever use the term leaky gut. We need to ban that from the profession. We need to ban it from the medical profession. It's a pseudoscientific term that's been co-opted by bad faith practitioners to sell supplements, an overly restrictive diet. Intestinal permeability, increased intestinal mobility is important to research. Leaky gut needs to go away because every time a genuine researcher uses the term leaky gut, some pseudoscientist on the internet gets more money. So we need to just move away from it. I know people are going to disagree with me. It's just a personal bugbear I have. We need to not use that term medically or dietetically. I suppose the good thing about, like you were saying, all that research that's going on, but I suppose if we just move on, I wonder if we can think about some of the challenges with the low FODMAP approach as well. And again, we'd be keen to hear from the audience or online what people think about this. So I know Ursula Philpott is going to talk in depth about disordered eating in this area. But, we touched on this, but do people think there are certain incidences where we've got to proceed with caution, or we need to think contextually about what we're doing with it?
Well, that brings us on to some of the questions that we're getting in online. Someone said, the low FODMAP diet isn't for every patient. The cost, the knowledge, the cooking ability, home situation, time scale. So perhaps that all needs to be factored in far more than just us looking at the diet and leaving it at that. So I don't know how you guys manage that in clinical practice.
Yeah, I think that's just comes back to the IBS, the complexity, isn't it? And going back to guidelines, I think we need to always remember that guidelines are very much a guideline and still really assess the patient, use that guideline as it's appropriate, really understand the research behind it. And then going back to that assessment side of things, spend most of your consultation, most of that time with that patient, assessing them, because if you get the assessment accurately and you get all the information, then actually your intervention you'll find works a lot better because it's so much more personalised. And I feel that's maybe where we're missing the link a little bit, but I don't know what other people think.
Do you find in your practice, sometimes people come with an expectation that that's what they're going to get, and then you have to walk it back and sort of maybe highlight other things?
Yeah, so I work in private practice, so people are paying money to see you. So they've come with that expectation, and certainly in the early days, even as a dietitian, I felt actually pressured to do everything all at once because they're paying for this outcome. But actually with time you get the confidence, and it's just about managing that expectation and even having the conversation that, look, this is my assessment, this is the science behind it, this is what we'll try first. It's not the only thing we've got, but this is a process, and I think if we can manage the patient expectation, generally the outcome is going to be much better, and they're going to be much more on board with anything that you suggest. But yeah. And
then as far as the panel are concerned, do you think that as dietitians we get enough training to do a thorough dietetic gastro assessment? It's very different to the normal ABCDE that we're all taught. Do you think we actually have the knowledge to do the gastro investigations and assessments?
Mm-hmm. Yeah, and I think that leads on to this roundtable panel discussion we had a couple of years back now about how we should be approaching this and having more autonomy and not being too rigid about how we approach it. And really we came up with this sort of infographic that we should be looking at dietary triggers. It may be that in the future, like Kate was saying, we'll have microbiome profiles that can guide our practice, or maybe other ways we can determine what might be most appropriate. But at the moment, we've really got clinical history and what we think might be appropriate socially, just like, what Emma was saying. And I think I do want to acknowledge that, I'm like a middle-class white guy, so I'm part of the problem in a way. We've got a white panel here, but I think we do need to be aware of cultural competencies in this area as well. The low FODMAP diet and other diets have applied primarily in a Western cohort, in a white Western cohort. We don't always know how that's going to work in different cultures. So I think we've got to have a little bit of epistemic humility about how we think about this, and then see the person in front of us. But in terms of sort of self-triggers, one of the things we thought, particularly that comes out of some of the research, and I wonder if we go on to our RCT, I think that's the next slide. Oh no, yeah, it was sort of bottom-up and top-down approaches. So we were thinking, like, we see the traditional dietary advice or first line, as well as the gluten-free diet as part of that sort of bottom-up approach rather than a top-down approach. And we did an RCT. We started it before the pandemic, and then it went over the pandemic. And this is predominantly my colleagues, Kirsten and Rachel, who did this. And they were driving out to get stool samples during the pandemic, which we dubbed the stool run. But I wonder if, Kirsten, if you could speak to a little bit about the results of the paper.
I think the main takeaway from the paper was that this is the first trial to compare traditional dietary advice, gluten-free diet, and a low FODMAP diet. And what we showed, and you can see on the slide there, that there was no statistical differences between any of these diets. So gluten-free diet in this cohort did work, and I don't know if members in the public are using a gluten-free diet, but we're not saying that from this research that it was a gluten-free diet as we would describe that for celiac disease. It was a modified gluten-free diet, but we did show some benefit there, and we could argue that this is probably a much easier approach to use than a low FODMAP diet. And really, I suppose it takes us forward is maybe we should start to tailor dietary therapies to that individual. We also noted that, the traditional dietary advice was easier to follow for patients. It was more acceptable, it's cheaper to follow. So it just shows that still has a real, place in the management of IBS, and I think that's key. But I think with the low FODMAP diet, yes, it works. We know it works. We know up to 80% may respond to it. But it's challenging to implement, it really is. Patients don't have the time. When you see a patient in clinic, and this isn't even if you're doing groups, sometimes you might even never see that patient apart from when you deliver your group and they get put on first line and second line. But if you're seeing a patient in a clinical setting, by the time you've done your dietetics assessment, looked for triggers in the diet, given them some personalised approach, and then they've come back for a review, and you've checked their symptoms again, you've got, 10 minutes to do a low FODMAP diet. So it really opens the question up. Should we be looking for easier to follow approaches, which can be personalised to that individual by looking at specific triggers or certain behaviours that individual has? And I think that's where these bottom-up approaches come in. And our study did show some benefit from a gluten-free diet. I'm not saying that it's gluten per se that's causing that. It may be that a gluten-free diet is just a way to reduce FODMAPs or fructans to a level that for some individuals, symptom benefit is achieved.
Yeah, and I suppose really we want to open it up, and I can see there's going to be questions because I think this is an interesting area, and we want to hear what people think. I think we did have, if we go on, Rachel, just to the slide after the infographic from the study, we've got some questions that we want to bring up because we think it is a bottom-up approach. It's a very familiar dietary concept, and like Kirsten was saying, we're not saying that it's got necessarily gluten's driving it. Again, I would say before we get questions, again, it's about having a little bit of that epistemic curiosity. We've heard a lot about the sort of mechanism with the low FODMAP, but when we look at data like some of the confocal laser endomicroscopy data, we know that wheat particularly can affect the small bowel barrier, and that's unlikely to be a FODMAP effect. So we're not saying it's gluten, but I think we'd still want to be curious. And this is an approach that does seem in clinical data, in our studies, does seem to have benefit. So we want to open it up to questions because we know it's a controversial area and we want to have that debate to see what people think.
Yeah, I think there was a question from in the middle there. Yep, great, thank you. Microphone's coming.
Sorry, I just wanted to raise the elephant in the room, really, because my problem is that at least 75% of my referrals that have some level of functional bowel thing, actually the referral says low FODMAP diet. So how do we stop our medical colleagues requesting a low FODMAP diet when they've not even touched on first-line advice?
So yeah, no, you raise a really good point. I think it comes back to what we were talking about earlier, really, that thing about us having autonomy and ownership. So it goes back to we need to raise awareness. It goes back even to the data I was collecting years ago when I did my master's about the inappropriateness of that. So I think we can only continue to challenge that over time, but that feeds into what we're trying to talk about now is us having individual options that are dietitian-led, and one of those things could be the gluten-free diet. We may have to, when people come in and presented, they may have gone online, we can't control it, it's not like drug therapy, but I think we may just have to, like Kirsten was saying, walk people back and say, look, there's a number of options. the low FODMAP diet has a number of phases. It's not just a restriction for life. So I think we can still have some autonomy in that situation. And one of those elements that we can do is look at using a modified gluten-free approach, which may be easier for some people. So, and I take on board, because we all find it very frustrating when that autonomy is taken away from us, because we are the experts in the area. But I think with this option, with things like the gluten-free diet, maybe in the future things like the Mediterranean diet, again, going back to Kate's colleague, Bill Che, he will say, the low FODMAP diet is one approach. We're going to have more and more personalization going forward.
Yeah, and I would speak to that. I mean, you have to get loud. I go to DDW and speak to the gastroenterologist, and the more you talk about, let the dietitian do the dietitian job, and physicians usually are very open to that. I know that varies country to country, but in the US, same with the GI psychologists that work, they don't want to be referred for gut-directed hypnosis. They want to make the choice for the patient. So I think it is getting in front of physicians at big meetings and speaking to this, that it does more harm, especially if they're not screening for eating disorders or really doing a comprehensive dietary analysis, which we did a study and it showed that diet education was 10 minutes, and diet education should never be 10 minutes. And one of the things, I know you said it is sometimes, but I have a screening tool that I use in my practice that the patients fill out prior to the appointment, and it really provides all those questions that we ask. There was no way I could do a low FODMAP elimination diet and do a full diet history, food frequency, symptom chart, etc. I had them to do that prior to coming. And I could have all that information and just look through it within 5 minutes that would have normally taken me 40 minutes. So I think there's lots of changes we need to make, but we also have to be squeaky wheels in front of people that are making decisions and putting low FODMAP diet on a prescription.
Yeah, and just to echo your point on that, I think as dietitians, this might not go down very well, but sometimes we might be very guilty of just getting very annoyed or angry about situations, but to see it as a learning opportunity, because I work with a lot of gastros, and lots of them will refer for a low FODMAP diet, but not one of them is actually expecting you just to do what they say. So just use it as an opportunity to assess your patient, do what you think is appropriate, but then when you write back to them or whatever your correspondence is, explain why you've done X, Y, and Z, and why maybe the low FODMAP diet wasn't appropriate, because we can go to meetings and talk to people, educate, but there's also, just conversations in the hallway. Letters back to the doctors is just always educating, because it's just coming from a place of innocent ignorance, I think.
Agreed.
I think, we need that ownership, and hopefully we get more autonomy. So I think I can see there's a question coming.
And to that question for you, as I'm probably the only medic in the room, David, I feel really strongly about what you've said, and I think the way to change that, most of us in our practice follow guidelines. We feel secure, and that helps us. You need to change your guidelines. And the first box of your guidelines needs to say, we'll assess the patient, we will assess them for dietary triggers, and we will then decide what dietary therapy intervention they'll be having. And the minute you've done that, you've got your autonomy. That's the solution. Medics, they're just like monkeys. You can just move them around, right? And so the zeitgeist in their head is FODMAP. I'll just throw that in the letter and the patient will go away and it's not my problem anymore. So if you change your own guidelines and the box starts with your personal assessment, and you're effectively saying there are so many options out there and you don't really know as a medic, but we will help you, then you're in.
I can see a few hands up.
I just want to join the dots up there a little bit then as well, because we talked at the top of the shop about the first contact practitioners, the advanced practitioners. So I work in a PCN and I get the opportunity to do that phase one. So maybe an opportunity to champion the role of dietitians in primary care in helping to do some of that individualised, personalised care for GPs to take on dietitians as part of their R's roles, their advanced, their additional roles reimbursement scheme as well. I think we can be invaluable and help to refer on to our specialist colleagues. So yeah, it's just to join those dots up really.
Pom's doing a good job.
I was just going to add that I've spoken to our gastroenterologists about the same problem. I think they're really open. We've kind of agreed we need to give them the strategy to, this is where you send your patients. We're promoting the webinars. And they've really been open to, you give us the information and we'll put it in our letter. I'm not going to say we're all the way there, but hopefully that's a good step on the way.
I think we've got another question.
Hello, and
Hi.
I also work in primary care as well, and the GPs have definitely found my clinics now, so they are sending them in. But another thing I found quite useful is to suggest which information to give to patients. So if you know there's going to be a bit of a wait, things like the BDA first line advice, and sort of if there's a bit of information about what the process would be and actually what the low FODMAP diet is, because a lot of my patients have only done that restricted phase. That's really useful as well.
So, yeah, I think it's important just to give that option if people are waiting within the context of how our services can work. Yeah.
I think questions from online, if that's okay.
Yeah. I'm just going to comment on the first contact practitioner post. I think you're in the perfect position there, because one of the problems we have with services, because there isn't enough dietitians, often it is group therapy, and not always is there a screening process being done at that level. So these patients are seen by a GP who's made that diagnosis and referred them through. We get a referral through, and it's for, fit groups or IBS, and they're just shuttled into that pathway without actually really undergoing that full assessment. Whereas you guys in primary care, working at that level, that advanced level, involved in the diagnosis and forming that diagnosis, you're at a really good place there to give that education to that individual, give some personalised approach, and then if you think it's appropriate for them to have that low FODMAP diet, you're in the perfect position to do that, and that's sort of taking out the GP, giving out some not so great advice sometimes, and I know it's time, but yeah, I think it's a really good place to be.
Concerns with the gluten-free diet being recommended. Yeah. So I kind of do have some concerns about recommending it when we're not convinced that gluten is the cause of the action, and the kind of overlap with the restrictive, like celiac diet. I know you talk about it being a modified celiac diet, but the level of anxiety I've seen in my celiac patients about the restrictions that they have, and then that is then mirrored in IBS patients who are put on a gluten-free diet, and the sort of limitations of that, and the fact that there's no talk of reintroduction, and if that's something you guys have thought about.
Yeah, thank you. So, so my primary job is working in patients with celiac disease. So, and I hear your concerns, and I think when I first maybe went into this area, I wanted to see, how we were going to apply this. We don't want to dilute the concept of the gluten-free diet as it's applied for people with celiac disease. We can talk about a regulatory framework of no more than 20 parts per million. Although I would say the gluten-free diet for celiac disease, it's not even codified at that level, because in different parts of the world, it will be no more than 3 parts per million, or in Argentina, no more than 10 parts per million. So we have this, it's not this codified thing for celiac disease even. But one thing I would say here is we have to think about what level of harm would it really cause. We're applying it in a dietetic framework. We're not saying it should be out there. I know there's a risk of that, but what we're doing is applying it in the context of this is a fructan reduction, and we would say for some people, if they present with a certain set of symptoms, and this is why self-reported symptoms are so common, because there's not only, there could be an overlap with celiac disease, there could be overlap with this condition, non-celiac wheat sensitivity, that we still don't fully understand, but there's definitely a scope there. And I think, again, when we go back and look at some of the research about patients that present without elevated TTG, without villus atrophy, but they're having responses at a mucosal level. There's, again, I'm not saying that's strictly IBS, but if we think about IBS mimickers that we're not going to go into too much today, we've taken things out of the IBS pot, haven't we? Celiac disease used to get misdiagnosis, pancreatic exocrine insufficiency. So there may be a cohort of patients in there that actually are having some genuine innate immune response to wheat. We don't know what's driving it, but it could be. And I think we've got to, acknowledge that from the data. But when we're talking about a gluten-free diet in this area, what we're saying is it's a version of a low fructan diet. Now, if we go to Marianne over there, sorry to single you out, Marianne, she has a wonderful low fructan approach as part of your website and a part of the, that's within the data there. But if we actually say to someone, I want you to follow a low fructan diet, what would be the advice? Would we really be telling everyone to have 100% spelt bread? Because that's a very small niche part of the population. I think we'd be telling them to have gluten-free foods. So we're not trying to, I think, be, sort of come up with a mechanism that doesn't exist. But I think when we think practically what we would tell patients in that situation, it would be to avoid gluten-containing foods. That's the way I would see it.
I don't know if this is on. Is it on? I think also the low wheat diet, almost rather than a gluten-free diet, is perhaps what it should be called, because it's part of one of many bottom-up approaches, isn't it? Really, it's just that wheat is such a major part of the UK diet that it's quite a natural one to reach for, because anybody who's tried to go out for lunch and not have wheat will know it's quite difficult. So it's not that wheat's a big baddie, it's the fact that actually it's such a high proportion in our diet. So by taking it out or lowering it, you're automatically lowering the amount of FODMAPs going into that patient. So it's about having a low wheat diet. I wouldn't even concentrate on barley and rye in those patients particularly. You're just doing an overall reduction. I mean, I've had a patient, for instance, who was having apples on stewed apple in the morning, half a litre of apple juice, apple something. And that was a bottom-up approach. We just took apples out and he was absolutely fine. He didn't need to do anything else. So I think wheat is just one of the bottom-up approaches. It just happens that wheat is very relevant. I think it's really important, and the lady there was saying, that we really promote it being a low wheat diet, maybe do it for 2 weeks maximum, just to see if it brings down the symptoms. And then it's really important to review that patient maybe a month after you've seen them and say, look, have you put it back in? Did it make a big difference? So I think it's the reviewing and the control of how long they're going to do it for, and that really stressing that it's not strict. We're not putting you on a celiac diet.
Yeah, and that's what we did in the research.
Sorry, to an extent, I think that, when we do the FODMAP reintroductions, if people here are familiar with that, we know that there are different categories of FODMAPs, and wheat fits within the fructan category of FODMAPs. We also have galacto-oligosaccharides, we've got the fructose, the polyols, and the lactose. So I think this is where it comes down to doing a really good assessment of the patient, asking them about what their trigger foods might be. And, if they can give you some inkling, you might then use this more personalised approach where, maybe if they are having wheat for breakfast, lunch and dinner, which is probably fairly typical in a Western diet, that might be one of the big top-down approach where you're thinking, okay, let's try and reduce that a bit. But you might also, if they've recently switched to a vegan or vegetarian diet, then perhaps galacto-oligosaccharides is part of the problem. So it is this personalised approach, not necessarily the gluten-free approach. It's the what category of FODMAPs do you look like you're responding to? And if they've got no idea, then probably a full low FODMAP diet is a sensible approach.
I would completely agree with everything there. I think what we're saying is we can unbundle the concept of FODMAPs a little and then see how it would apply. And I can see Dave Sanders, Sheffield.
Just to allay your fears a little bit, there have been 2 long-term FODMAP studies published looking at real-world experience. What do patients do 12 months later on a FODMAP diet or further? And both of them had the same message, which is that many patients were substituting and putting gluten-free into their diet. So they were doing it of their own accord. And if you have friends who are decide to go down the FODMAP route, when they go into restaurants, that's what they ask for. They don't say, excuse me, do you have a fructan-free pizza? They say, could I have a gluten-free pizza? So it is happening for real. It's what the patients are doing. So it's not a full gluten-free diet, so you shouldn't really run the risks that you may have concerns about, but they're actually doing it for themselves. So we may as well try and support them and give them clinically valuable information and hopefully allay their fears.
Can I just add? There's something, as I said at the start, about a balanced approach and not going to extremes in all of this. And to me, it's about reducing some of these things in people's diets rather than eliminating. And sadly, the low FODMAP diet approach has actually centred a little bit on elimination initially, whereas I've used Marian's example there of the apples, that's about reducing these things in people's diets, and obviously fructans from wheat, for example. So perhaps we don't even need to have a gluten-free diet to get benefits. Perhaps it could just be a reduction in these things that are causing some level of fermentation or osmotic effects in different people.
Yes.
It comes back to self-reported symptoms for me. I can think of, just like Marianne, I can think of someone comes in, we're referred for a strict low FODMAP diet, I'm drinking a litre of mango juice in the morning. That's a very easy solve, you know, it doesn't have to be a strict approach. But when someone's coming in and they are reporting, you know, they're eating a high level of wheat-based foods or other, you know, foods that would fall in that gluten-containing category, again, I think it can be, and again, I would come back to, I suppose I would say, is what level of evidence would we require to start using it? We have an RCT. It's one RCT. I'm not saying we've got multiple RCTs, but in the real world, when we've asked patients to follow a gluten reduction, it has actually benefited them. So, you know, I think we have to come back to, yes, we can have some concerns about the nuances, but if we're taking on board that message of, you know, what patients do long-term independently on their own, we have to take that as a signal. And I think if we can assess those patients individually, have that autonomy, this is just one of a number of tools that maybe will fit for some patients.
I think that fits quite well with some of the questions we're getting online.
Sorry. Yeah, so everyone's sort of commenting on that individual approach and how do we actually make that shift when we've got such a push for group sessions? How can we actually still have that individual approach out of the group settings?
Yeah, so we've got thoughts about how we could develop this. I think, you know, again, there's a number of different, again, I feel I'm singling out Marianne all the time, sorry, but, you know, there's a number of different approaches being developed, and I think work that you're doing as well, Emma, is coming up, and work that Rachel's going to be doing. You know, we can scale this up, and I think maybe this comes on a little bit to maybe, as we tailor down at how we maybe use some of these alternative service delivery methods. I suppose if we go on maybe to the next slide, maybe Rachel. So one of the things we were thinking about is like digital delivery, and are we ready for dietetic digital disruption? How we are taking this on board. And I know there's a number of different things out there, but I think this is going to be scaled up. So this is one way we could offer different personalized approaches, you know, when we're working within the context of the NHS. And I can see questions coming in. Go for it, Marianne.
Well, one of the things we set up with our clinic was that people fill in a triage form. So everybody who's referred gets a triage form. And on that triage form, it's got all the questions, whether, you know, everything for the IBS symptoms, red flags, allergy symptoms, you name it, it's got everything on there. So we could immediately put to one side the people we thought, this needs a personalized approach, needs to be seen one-to-one, they're not suitable for the digital delivery. So everybody else could go to the digital delivery, which worked really well. And we're just about to publish research on patients who have started the FODMAP diet from anywhere in the UK. We don't know them at all, there's no background to them, and we followed them up 8 weeks later with contacts, so they've agreed to take part in the study, and that research is going to come out soon, showing some really good results. And those people aren't triaged, of course. So what we want to show is that digital technology can work safely, but from a practical point of view in clinic, I think the triage forms are fantastic, because then you've got a lot of your questions answered, and you can then decide who's going to go to group and who's not.
And hold that thought, because after lunch we're going to have a very interesting talk from Rachel as well. Yeah, I think, Emma, do you want to comment about some of the things you're thinking of as well?
Yeah, absolutely. I think, you know, there's a big shift for automating and digitalising triage of our patients. And if we don't have that thorough triage, it's going to make it really hard to put in place the personalised advice. So what we're sort of working towards at Guy's and St Thomas's is having a really thorough digital triage that hopefully we could potentially then validate in this population and use as a really good gold standard, so we can then support those teams that are perhaps not well as funded in their gastro services. And then we can then use the, you know, shared learning and have a bit of a hub and spoke model, so we can kind of bounce ideas off each other and make sure that those smaller teams are being supported. But the digital element is so key to that. And I think, you know, looking at digital healthcare, we've got to make sure that it's accessible for those that are then digitally challenged as well. Digital poverty is still a real thing. And also in terms of literacy age, you know, the national reading age of the UK population is between ages 9 and 11. So it's quite low. So we've got to remember we're dealing with a population here where not everyone can engage with that content. So we've got to really enhance digital and make the most of the time saving and cost saving that's giving us, so that we then have the time to put towards those patients that perhaps aren't able to access the digital resources. So I think there's going to be a lot of big step forwards in the next few years, particularly with automating things, using AI. You know, the robots aren't all bad. I think using AI in dietetics is going to be really revolutionary. So if there is anything digital, really good to jump on it.
I think Nick had an interesting experiment with this, actually.
Yeah, so I put this out, sorry, we'll come back. So has anyone heard of ChatGPT? Yeah? So I put this question into ChatGPT, I can't quite see, describe the reintroduction phase of the low FODMAP diet for people with irritable bowel syndrome in a table format. And that's what it came up with. Now, we could say there's limitations to it, but I was quite surprised about what it offered. It's a reasonable stab at what maybe we would say in a very generic short-term statement. I'm not saying it's would any way constitute what we would do as dietitians, but I think this is at the beginning. We're at the first rung of the ladder with this. So if we don't acknowledge, I think, how this may affect our practice and what patients are going to be accessing, I think we're going to miss out. We've got to be in there at the ground level trying to sort of think how this is going to affect our practice. Has anyone got thoughts, or do people presenting at your services?
Yeah, we use ChatGPT in our service already.
Wow.
So what we found is it's almost like, if you think about it as a business sense, it's a way of outsourcing things, so you can save more time. And then you can use your time where dietitians are really needed. So we use it to produce education content, and don't get it wrong, this is not 100% accurate, so you still need to go back, do your references, check what's in there. But as an example, if I was using this, I can do 20 blog posts in a day, whereas if I'm writing on my own, I can do 2, 3. So that then saves a lot of time to then do other things where really a dietitian is needed. So this is a quite basic way to use it, but I think AI can offer a lot, so we can progress the profession quicker, we can offer more services, and just really use, our brains where they're really needed, and use that kind of AI support in other ways.
I think coming back to the digital triaging, which I don't want to kind of talk too much about what you might, but so digital triaging is happening when patients are referred for IBS dietetic advice, and they will then complete a bunch of screening that doesn't require the kind of the time from the dietetic assistant or whatever.
Absolutely.
Do they then also receive first-line guidance through that process, or how is that managed?
Yeah, so I think the idea is that we've got really good, clear transparency about what is actually going on with that patient, so we can identify which bit of first-line advice is relevant. Because not everybody has an issue with having unhealthy foods. Perhaps it is more of the diet and the lifestyle elements or the psychological elements. So the idea is that the triage forms give us that transparency, and then we can offer them those individual bits of advice before perhaps they are seen individually. So I don't know if that's what anybody else is already doing or putting into place.
I think Amanda's.
Yeah. So obviously, ChatGPT is really concerning from an ATI point of view. So ATIs are behind the scenes navigating their way around ChatGPT and other AI forms. But just going back to, I think, Emma's original question about groups, so moving away a bit from the digital, but going back to the groups, and obviously thinking about the fundamental role of the dietitian in terms of doing no harm, and really groups for the first-line dietary management, which is actually a bit of a modified low FODMAP or reduced gluten diet in some respects, can actually be really, really well placed. So to me, groups provide a really great platform to deliver support for people needing and benefiting from first-line dietary advice, because their diets are likely to be more nutritionally balanced, which is thumbs up, because often people have been on quite restrictive diets, so nutritionally imbalanced, et cetera, et cetera. So to me, for first-line dietary advice, which should be made to be the priority, they're well placed.
Yeah. So I think we're getting close to time. Has anyone got any questions before we wrap up? Christian?
Thanks. I think it's fantastic discussions, and we've got some experience over at Bradford with using doctor software too, and I think it's a fantastic opportunity. And I think, really interesting with what you've said about groups. I think, technology also allows us to track symptoms with these people who attend clinic, where usually we wouldn't be able to do it because we're not doing a one-to-one. So it gives a really good way to then also track a lot what we're trying to do with the outcomes too within services. So I think they've got fantastic potential for these many different different reasons. I think the more you start, utilizing it, the more you realize, it can really help. We can actually give advice to patients whilst they're waiting, not just take information from them, but give it to them too. So I think it's fantastic. But I think one of my concerns with all of this is that it's always very hard to take that first step and establish this within a trust. So we were very lucky to get a pilot at Bradford. It's worked really well, and thanks to that now, the whole hospital is using it. It took a lot of work to do it, but I'd be curious to see how many dietitians actually have access to this, or what the barriers are there, or what people think, what we need to do to kind of get this as a bit more standard procedure within dietetic practice.
Absolutely. I'm really excited. Looking forward to your talk this afternoon.
I think we'll just take another question from online before we wrap up.
Yeah, absolutely. So one of the questions actually came in about screening for eating disorders. So, how are you actually doing that in this patient group? Because it can be a little bit complex, and it can exclude them from a lot of treatment. So how are you approaching that in practice?
I would want to see what Kate had to say, but I'm going to caveat it just to say Ursula is going to talk on this afternoon. But I think Ursula's got a hand up. No. Yeah, but have you got some thoughts, Kate?
Yeah, so if we suspect eating disorder or severe maladaptive eating, usually we convert right over to behavioral therapies as first line, and make sure that they get an expert eating disorder dietitian and therapist intervention. Most GI dietitians, and I don't know if that's true here, do not have the education in eating disorders that really, it's a very high risk of suicide, mortality in that patient population, so we want to make sure we escalate that pretty quickly. At the same time, we don't want to slap an eating disorder diagnosis on someone that innately has a lot of pain with eating, and it's very nuanced area. But yeah, certainly want to be careful with strict elimination diets, and really it's not like we say see you later. We are providing supportive nutrition care to the patient, and often I'm working hand in hand with the eating disorder specialist to sort of navigate the diet too from a GI perspective without really alluding the information to the patient, what we're doing.
Yeah, I can only speak to that as well. I feel like I've been so lucky and privileged to do some work with Ursula, who's going to speak this afternoon. And as a gastro-dietitian, I've learned so much from working with an eating disorder specialist dietitian. And again, some of the work hopefully me and Rosie are going to do, hopefully in the future, can speak to some of this, that we can develop some more national approaches. So, but we'll keep the powder dry for Ursula this afternoon.
Yeah, I've got another question over here, sorry.
Really interesting panel discussion. And what I wanted to say, I think it really highlights how we've moved on from over the last few years. And with my hat on as the research and policy lead for the gastro group, I wanted to highlight that the guidelines, IBS guidelines, are in the process of being updated. And the breadth of discussion that's involved today is so important, that they are broader and encompass more aspects in dietetic practice and IBS. And those of you that, sort of a plea as well, that those of you involved in research in the digital provision and apps and all those sorts of things, to really look at outcomes, because when we're doing guidelines, we look at evidence base. And we need that evidence base to be able to say, let's go forward with this. This is our recommendations. So I just wanted to say thank you, panel. And the IBS guidelines are moving forwards.
Thanks.
We've just got a few minutes left now, so I wondered if there were... of course.
Just following on from Yvonne's comment about future research, and I think the thing that we've not touched on, but it's been alluded to, is in terms of access and availability of the advice for people with IBS. And what we don't see in the literature is very, very little in terms of outcomes looking at health inequalities. And if you think about the need for sort of a certain level of health literacy, a certain level of financial ability to be able to afford, let's say, a low FODMAP diet, for example, clearly there could potentially be health inequalities in this area, but the evidence base to date has not been really that great in terms of acknowledging the fact that we might actually be increasing health inequalities in this particular population group. So just a plea in terms of future research going forward.
I'll actually be speaking. We did a small study that hasn't been published yet, but I presented at the American College of Gastroenterology looking at that exact question, is the low FODMAP diet for rich people only, was a question posed to me at a webinar, and I said, yeah, it probably is. And is that okay? That seems like that's not health equity. So we polled the American College of Gastroenterology providers to say, patients, I apologize, and looked at their social determinants of health and found that, and I'll discuss this later briefly. Now I won't have to, so I'll have plenty of time during my talk. But the bottom line was that if they had lower educational attainment, difficulty accessing food, and one other variable, they were not getting referred for the low FODMAP diet. And certainly that makes sense maybe in some ways, but on the other hand, if this is one of the most evidence-based diets and they don't have access. So I'll talk a little bit about some of the information that we've pulled from that. But
I think maybe on that note, because we can lead this into discussions into lunch as well. So we just want to break for lunch so we've all got sticking to time and everything. But I just want to thank all the panel for speaking and our wonderful moderators. Thanks for all the interesting questions. Hopefully that stimulated a bit of debate that we can carry on with. So look forward to catching up after lunch, everyone.
Who's chaired again?